All right, hello everyone. Welcome to our webinar. Thank you for joining us today from the McMaster Health Forum here at McMaster University. And those of you who are joining us in the room, thank you very much for coming. And those who are joining us online for the webinar, thank you very much as well. Quick agenda for today's events. I'm going to tell you a little bit about the McMaster Health Forum, a little bit about the scholarship program, and then I'll introduce you to our guest speaker today, who is Benard, who is one of our incoming scholars. So the McMaster Health Forum is a leading hub for improving health outcomes through collective problem solving. We aim to harness information, convene stakeholders, prepare action-oriented leaders, and be an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between Rideau Hall Foundation, Community Foundations of Canada, Universities Canada, and Canadian universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The Queen Elizabeth Scholarship Program at the McMaster Health Forum is called Strengthening Health Systems, and our scholars contribute to strengthening health systems and become part of our large and growing network of health system leaders. Here's a group of our first cohort of students. Our presenter today, Benard, is the last of these scholars to do their webinars. In the fall and winter of 2017 and 2018, you will see some of the webinars by this group of people, which comprises our second cohort of students. So with that said, I'll introduce you to today's guest speaker, our incoming scholar, Benard Miregwa. He is a citizen of Kenya who is here at McMaster taking the Health Policy PhD program, so he's a doctoral student. His current research interests include health system strengthening and health policy analyses that focus on improving public health outcomes, including combining research that evaluates pharmaceutical policy analyses, health technology assessment, and access to health services. Prior to his time here at McMaster, Benard held various senior positions at the Ministry of Health in Kenya, including the Directorate of Policy, Research, and Development. So without further ado, Benard, I'm going to turn it over to you.
Thank you, James, for introducing me, and those of us who are online, and also those of us who are in the room. I want to welcome you to my QE Scholar presentation, and I'll be my topic will kind of focus on the failure of universal health care coverage policy reforms in Kenya, which is a case of policy legacies and positive feedback effects. And the way I've structured my presentation, I will introduce the background where I will give more information about the overall governance and policy arrangements and arrangements in healthcare, the way healthcare is delivered in Kenya, then introduce the key concepts of the framework that I'm going to use, which is a Pearson 1993 framework, specifically give an overview of specific policy legacies in Kenya and their effects on the three key actors, government elites, interest groups, and mass public. And I will also discuss the limitations of my analysis and finally present the conclusion recommendations of my analysis. Now, the goal is key here is basically we need to understand why did Kenya fail to implement universal health coverage policy reforms. And it's important because then in order to inform future proposals, understanding the recommendations out of the analysis that I conducted will also inform future reforms. So it's important for us to go through this. And the background I will kind of focus on key questions that I'm asking is basically why did Kenya fail to implement universal health coverage policy reforms in 2004, 2007, and 2009. Again, make use of the Pearson 1993 framework to organize my analysis and explain why the failure of reforms in Kenya. And to give a bit of background in Kenya, the way political system is arranged or is structured in three arms. We have the executive arm that is headed by the president, and of course the president also in Kenya happens to be the head of the state. So the president wears two hats. He is the head of the executive arm of the government, but also in Kenya we have two more arms. We have the judiciary arm, which is headed by the Chief Justice as the President of the Judiciary, and their role is basically to ensure there is justice. And the legislature arm that makes legislations in the country, which has all the elected members of parliament. So again, those are key arms of government, but also I want also at this point in time to point to you from independence to 2010, the structure in Kenya had only those three arms. But after Kenya introducing the new constitution, we introduced another layer of the county governments. So in this case, you have the county governments on this end and a new system at the national level that kind of formulates and puts legislations in place that support the county government. So again, in the county governments, you have again two wings, which I will unpack shortly. So how are the county governments organized in Kenya? You have the executive wing headed by the governors, and then you have another wing, which is the county assembly with the speaker and elected members. So it's like another legislature at the county level. So you have the same system that is at the national level, replicated at the county level for accountability purposes. Then you have also the governor appoints the deputy governor, the executive committee, known as the county ministers. Then you have the county directorates that had all the services that were devolved, because I will kind of go in my next slide, discuss detail how the mandates of the two systems of government, so that it's easier for you to understand if you get to Kenya what is happening specifically in Kenya. But again, when you look at these county services, healthcare is one of those services that were fully devolved, and we'll see how does that play in terms of the future reforms that have to happen in Kenya. Then the checks and balances that exist between the two levels of government also are important, because then the national government operates independently and the county government operates independent, but they have mutual relationship in terms of, because their mandates are kind of distinct. So it's important for us to understand that. And why this, for the county governments to operate and to come to full operational, they need to have legal instruments or policies and legislation put into place, because those then policies will establish institutions of the county governments to start operating. And that's why you have the different policies that are coming into play. Now, this is giving a bit of background of healthcare delivery arrangements that we have in Kenya, because on one end, the national level has the mandate of specifically its policy and regulation. So when you talk about policy and regulation, and because it has been there for a longer time period compared to the county government, it has another role of building the capacity among the county governments to start running and delivering the services that have been devolved to under their mandate. So again, when it comes to the mandate of the county governments overall, especially when it comes to healthcare, they deliver healthcare services, because almost all the facilities that were under the national governments before the new constitution came to being were devolved to the county governments under their mandate and their administration, except only two hospitals. That is the teaching hospital, the government national teaching hospital. And those specific hospitals Why they could not be transferred to the counties? Because they are the overall teaching hospital in the country, and again for referral purposes in cases where the county government or the county referral system, they have cases they need to refer, they don't have the capacity to handle those particular cases, then they transfer or refer those cases to the national government. So again, this is basically how care is delivered in the country, but the figure that you are seeing or the structure that you are seeing is basically for the public healthcare facilities. The question again then, what about the private healthcare facilities? Then private health sector is also distributed everywhere, because then it doesn't fall into the mainstream public administration, because in Kenya we have two wings of the two-tier system. So you have the public healthcare delivery or public healthcare facilities, and then you have the private healthcare facilities. Though for them to operate, they need licenses, which they again get from the Kenya Medical Association and the Kenya Medical Dental and Practitioners Board. So again, for checks and balances, so you will see shortly the two arrangements and how they played in terms of understanding the policy reforms in Kenya. Now, introducing the concepts of the policy legacies and positive feedback effects, here the key, what we need to understand is past policies influence distribution of resources and powers, and in turn they also affect how various actors, namely the government elites and the mass public and interest groups, kind of position and their choices they have and how policies get passed. So again, in terms of interpretative effect, they refer to the manner in which past policies and choices provide meaning and information that shape or fashion the worldviews of actors, and in turn they respond to development of policy. So it's important for us to have an understanding of this framework, because this framework is very helpful in terms of helping me the analysis and the explanation of my presentation. And the framework that we are seeing here is basically the Pearson 1993 framework, and it's a 2x3 table which has 2 pathways and 3 actors. So it's basically in total 6 pathways, and the effect that this table has, you have different past policies, distribute resources and incentives, and the effect those resources have on key government elites, interest groups, and mass public. So we have 3 actors in play, and how the past policies end up ensuring administrative capacities, and how the different interest groups get organized, and if they are privy to finances and they are privileged in terms of the past policies that they passed, they then either become their stronger groups or their weaker groups. Again, this framework also helps us, the interest groups, we kind of, it's embedded or is based on the concentrated benefits and the diffused cost of own framework, which again is very elaborate as I go by. So the lock-in effect happened to the mass public, and of course over time there's learning and feasibility. If you find there's commitment and allocation of resources, or that kind of the benefits that get to the public, or the majority of the people are powerful, and you tend to change those particular policies, then there is a protest that may come out, and that is what we talk about. We refer to feasibility or traceability. So how did it happen in Kenya? So it's important for us to understand this, then, and giving specifically an overview of specific policies that were there from when Kenya got its independence and moving over to the 2000s, when there was a failure of the implementation of the universal health coverage. It's important to understand the story as it goes, because then initially Kenya has all along established different policies and registration to organize and deliver healthcare services. And in 1966, the National Hospital Insurance Fund Act was put in place in Parliament, and that sought to replace the discriminatory arrangements that was there before, whereby Kenyans were forced to pay for their services out of pocket, introduced by the pre-colonial government, the colonial government. And after that, immediately Kenya got its independence 3 years after they introduced this policy. And this policy was meant to ensure there is care at the facility level, but it focused on inpatients. But also, it's important for us to note another policy that came after the 1966 NHIF that we are going to focus on its effect is the 1990, the cost-sharing policy. And the CSP policy was introduced and mandated the public health sector to mobilize additional resources in the health sector and also minimize the overuse of resources and enhancing functioning of the healthcare referral system. And why this CSP policy came to being, you remember in history, in the 1980s towards 1990s, there was this introduction of this, the structural adjustment economic programs that was put into place, advocated by the IMF and the World Bank. And because most of the low and middle income countries were moving into recession and they were accruing a lot of debt, so there was all that kind of caps and introduction of these kind of policies to try to ensure that the debt is managed. And of course there was cut down on social programs, including education. And the effect of this policy was immense. We will discuss that. And of course, lastly, another policy and its effects that we're going to kind of have a look at is the National Social Health Insurance Fund legislation that was presented in Parliament in 2004. Yes, it passed with mixed reactions and eventually didn't got accent of the president and returned back to government for further deliberations. And since then it never everything stuck. And you would understand from what you have already discussed the powers that have been granted by the president, different political elites, and those powers were given by the past legacies, and that the president has the power to accent, and if he refuses to accent on particular policy that has been passed, then again it stands to be null and void. So again, it was taken back to Parliament, but it was never implemented because of the, again, opposition that came out by the many other interest groups. So using the framework that we went through, it will help us to understand why really Kenya didn't go through this and why the failure has always been there. So, and the hypothesis we made at this point in time is the path followed by Kenya could be explained by policy legacies and positive feedback effects to the extent that political and historical paths over time locked in its different healthcare policies. And specifically, then now going to each of these policies, for example, like the NHIF Act, when it was set up because it focused on the formal sector employees, it left out the informal sector employees and those employees that were at the private sector. So ensuring, bringing up a system that is segmented and fragmented. And also the plan excluded outpatient and still excludes outpatient services, thus limited incentives to those willing to enroll. So the pooling people who are into that program or the NHIF program are few. So again, when you talk about insurance, you need numbers of people to be successful. later, due to mistrust, because again, initially when the NHIF was put in place, it was as part of a department of the Ministry of Health. And that in itself, because the way it was structured, limited its administrative capacities, and the inefficiencies that happened to occur in the running of the NHIF spilled over, and the learning that took place over time resulted into many other, even when it transitions into a state corporation, its enrollment still has a challenge of enrolling more people, and thus a pooling challenge. Discussing through the effects of the governmental elites, you have the different administration, and these are the presidents that have run in Kenya from the time Kenya got its independence and to the current president. The first president is Jomo Kenyatta, and he is crucial because he reigned when Kenya passed the National Health Insurance Fund Act. And then Moi came in to succeed Kenyatta when Kenyatta passed on. And Moi also was instrumental because when Kenya passed the cost-sharing policy, in other words known as the user fee policy, Moi was in power during the economic restructuring of program. Then you have Mwai Kibaki, president, the third president of Kenya, who was in place, and he's the gentleman who did not sign the National Social Health Insurance Fund into bill. So you understand why these three different and four different presidents have played a role in terms of the current state of events in Kenya. And the two presidents lived the time when Kenya served under one-party system, and the rest from 2003 onwards, Kenya has a multi-party democracy system that came into play. And it's important at this point to flag out that these past policies affect the extent to which administrative capacities introduce reforms, initiative to existing policies, and the political system. Understand that in 1999, the cost-sharing policy had its effects. When it was passed, it had three key effects. It exposed the weak to incur high catastrophic costs because they were paying out of pocket, and these had negative implications. And also, it weakened the capacity of those, the weak and the poor, who could not really get services. So again, they compromised because the poor could not seek or were unable to seek care. And also because at that particular point in time, there was cost sharing. People were paying at the point of the use of services. It gave incentives to the private healthcare sector to grow, because then they had business to do if they establish the private healthcare sector. And this encouraged the growth of the private healthcare sector, and because there was a lot of resource incentives that were, and of course they had all these spoils as a result of our framework. They ended up investing and establishing a very strong private healthcare sector. And currently, the overall kind of share of the private sector is at 62%. So again, one other thing you realize, most of the government elites make use of the private healthcare sector because they are perceived it's perceived to have quality, and the efficiency is higher compared to the public health sector. And especially the last bill that came to effect, the National Social Health Insurance Bill, was highly controversial despite passing Parliament in 2004, because it had resistance from several stakeholders, and including the key political elites who have their own interests. So some of the political elites, they had their own interests, and some of them did not support the policies. And eventually, even if it was passed, still, again, the entire private healthcare sector and many other organizations were not ready to support the policy, the legislation. Now, the reforms were consequently thwarted both in 2007 and 2008. And because of the adaptability over time and the continuous failure of the reforms that were there before, it resulted to low feasibility, low traceability. The public was already weakened, so they didn't have strong organized group to fight against it. So again, because the way Kenya, the way policy-making process is structured, it's more the political elites, especially the legislature who make policies, and less engagement of the public in the entire process of policy-making process. So we didn't see a lot of protests in terms of the policy, especially the National Social Health Insurance Fund bill. It failed in 2004. Now, interest groups also play a very important role in this case, because other than the political elites, as per our framework, past policies, which is part of institutions, which are rules of the game, shape human behavior. And we see they could either limit or strengthen specific groups of interest through cutting down or providing resources regarding financials, and in turn increase or limit access to decision makers. And specifically, in this case, you'll find that if resources or incentives are, if one group is privy to resources and incentives, they will mobilize and more easily lobby to protect their common interests. For example, the private sector and the political elites, interest groups. And that exactly happened in 2004. And specifically to bring to play of all those key interest groups, we had political officials, civil servants, researchers, policy entrepreneurs, and again, the model behind understanding the various interests is basically the who wins and who loses. And when this policy was put in place, who was going to win and who was going to lose. And more you find if the people who benefit from a policy decision and they are more strong and they have more organized, they have access to resources, then they have the capacity to fight and determine the overall and outcome of whether that policy will pass or not. And if they are weak, then the opposite takes effect. And also, it's expected that individuals and groups facing concentrated costs and benefits are more likely to mobilize and form coalitions in pursuit of their interests. And if, in contrast to those who face more diffuse costs and benefits, so if you have more benefits out of it, it's the concentrated benefits, then you push for it, and if it's diffuse benefits, then you kind of stay aloof. So again, this played a bit of the background that I'm giving, especially the NHIF Act and the CSP legacies gave rise to a segmented system. The public formal sector was already segregated or was fragmented. And of course, eventually in terms of the people who are contributing into that particular system are less, so the pooling challenge was an issue. And then because of the CSP encouraged out-of-pocket payments, so eventually the poor underutilized healthcare services, and if they are underutilizing their services, they're weakened, and they could not afford the healthcare service. And again, the arrangement, the way it is, it kind of increased the inequities between the rich and the poor. So the gap between the rich and the poor went up, those who are able to afford healthcare services and those who are not able to afford healthcare services. It's also important to flag at this point in time that during the expansion of the private healthcare sector, uh, most firms came up to establish their healthcare, the private insurance firms and also the private healthcare facilities. And at this point in time, of course, they had an incentive because they were into business and they got to be more organized and they got to be stronger. And over time, because most of the politicians and the rich went into their facilities. So again, in terms of establishing and strengthening the public health facilities, there was no, it was not a priority to many politicians because all the policies that have to pass, they have to be passed at the parliament, and all these MPs, they were rich, their families and all those who could be able, who are able to get care, they always seek their care in the private healthcare facility. So you see the rise of the private healthcare sector and the quality of healthcare sector, the public healthcare sector is still questionable. And some of you who know, just a few months ago, Kenya doctors who are in the public health sector were under strike for almost 3 months because of the same thing. They were kind of heralding their cries. They needed to the public healthcare sector to be improved in terms of quality because most of them are not accessing all the equipment and the drugs they need to be able to offer the quality of care they need to the citizens. And even going to a level whereby they wanted to have all the legislature and the key government employees to make use of the public healthcare sector so that by doing that, by just automatically they have to kind of make sure that the state of the quality of service offered and there's more investment into the public healthcare facility. Yes, Kenya was one of the countries that signed a budget declaration that says 15% of the GDP should be made use in the healthcare, but still currently Kenya stands at 9%. So there's that kind of gap. And this is basically what different stakeholders and interest groups had to say when the National Health Insurance Fund was presented and when it failed in 2004. And you see out of the most of the interest groups and organized groups that were there, only one group kind of agreed to support the NHSF, the National Social Health Insurance Fund bill, but the rest of the groups, including all the medical organizations, the Nurses Association, and the key figures, all of them had questions and in terms of support of the National Social Health Insurance Fund. And when it comes to private healthcare sector, they were the first people to say private medical schemes and quality private will be suffered because then again they were at the first from because they had concentrated benefits on the same to kind of say no, wait a minute, the route that we are going is not going to be so helpful to ensure that care is delivered to the Kenyans. So what about the mass publics over time? Because of the past policies that we already have seen, they were already divided, and of course there was discontent among the public and are also the past policies, if the public's already weakened, then they will not protest. So again, they are already weak, they are used to adaptability as is part of their life, they are used to paying out of pocket. So it was, and again, they were not engaged in terms of the policy making process overall in Kenya because of the institutions are weak compared to developed countries. And so you have all these past policies, the National Health Insurance Fund Act, the cost-sharing policy and the National Social Health Insurance Fund Bill gave rise to a segmented populace. They weakened the populace with low expectations, especially those without any coverage. And over time, the adaptability and the fragmentation that was already entrenched in the system resulted into locking in effect of discontent with the current healthcare system, thus low visibility and trustability due to low expectations as a result of repeated policy reform failures. So again, the rich continued making use of the private sector, and of course their families too, the politicians too, but also the informal sector was not covered. So again, pooling challenges also arise at this point in time. So we're looking at this in summary to just pull up everything together. You see, this diagram helps us to understand if all our three policies are here, the National Health Insurance Fund, we have the cost-sharing policy, and we have the National Social Health Insurance Fund, and how those particular policies, whatever we have discussed, shaped the way business happens or the healthcare delivery is conducted in Kenya, resulting to path dependence. And of course, the current state of issues, if those policies like the National Health Insurance Fund and the cost-sharing policy, which passed, resulting for those policies to be institutionalized and therefore determined how care was offered over time, and leading to all the affecting the three key actors, the interest groups, by strengthening the organization, having the government elites by determining their administrative capacity, and the mass effects had no commitments and lacked, because of the adaptability of out-of-pocket payments, and these resulted to low visibility and the current state of affairs the way they are. So just giving this as an overview, kind of, again, the critical junctures, a key aspect whenever you discuss policy legacies, but again, they may be endogenous within. Maybe over time, the Kenyan government changed administratively every time we had elections that elected new leaders, and of course, bringing into being new leadership, which is internal changes, and of course, the external changes you saw in the recession, economic crisis, and of course, but specifically to address the policy feedbacks, I guess this has been very helpful in terms of understanding why Kenya failed to implement the universal health coverage policy reforms. Now, limitations of the analysis first, we focused on secondary sources. The framework may not exclusively have captured all the aspects of policy making, especially in low-income countries. And thirdly, policy processes in Kenya may not exhaustively and comprehensively engage key stakeholders, such as the public, organized groups, such as the government elites. And in conclusion, the framework, Pearson framework, was helpful in terms of understanding why Kenya failed to implement the universal health coverage policy reforms, and also recommendations that come out of the analysis. First is stakeholder position may be minimized by establishing efficient structures that engage everyone, that includes the public, private sector, and other stakeholders. Also, the overall delivery of services should be responsive to the needs of the population, and the coverage should be all-inclusive regardless of the status, to enhance pooling of resources, enhance administrative capacity, and prevent fragmentation. And lastly, issues of trust, transparency, and good governance structures that promote accountability are critical in future reforms are to be successful. Thank you. That is the end of my presentation.
Excellent. Thank you very much, Benard. I'll just pause here for a second. And those of you in the room, if you have any questions, please put your hand up and I will repeat it for those online. For those of you who are online, I'm going to ask that you please use the chat box and type your questions in, and then I will read it out for everyone to hear. So I'll pause for a second. Anybody in the room interested in being the first to ask a question? Or anybody online? Yeah, go ahead. So the question in the room has to do with Benard's thoughts on how we can build back trust in the public in terms of the system, and because there's been a lack of trust in that regard. So Benard?
Thank you for that question. I guess the key aspect in terms of how trust could be improved is basically it all ensures in terms of how the structure has been before, because the public are not engaged in all the policy, day-to-day policy running and the way policies are implemented in Kenya. So involving them and engaging them more in all the processes, starting from the time the policies are, before the policy is formulated, and even the public being at the center of giving their suggestions in terms of how all these policies need to be pulled together. Again, they feel included and that particular point in time. And I guess as the new system is coming into play, when I illustrated the new structure that has come into play, it has a lot of checks and balances, giving more power to the general public who have been weakened. And I guess if we will have them more involved, that will really help in terms of improving the trust. And of course, in terms of the way the government structures are, the government officials and the civil service is structured, is more of accountability, because then in terms of, initially there was no accountability how those who are on administration, they run their services, but because of the new structure of administration that is in place, of the systems that have been put in place, I guess the leaders are more accountable to kind of make sure that they are running and running day to day. They are accountable in terms of how they run the offices that have been appointed to.
The basic question in the room is, where is the Kenyan healthcare system now in terms of discussions about where to go next? So what are their plans and any reforms on the horizon?
Thank you for that good question. So currently what is happening in Kenya, I guess, again, the speed of implementing the universal health coverage was a bit went down because of immediately the Kenya failed to implement the universal health coverage in 3 subsequent rounds, I guess, affected how the previous reforms will, but I can't say that that is the end unless you have, again, new political leaders coming up with these kind of policies to start running up and down to implement this. But I want to also mention that it might be, we don't know how long it may take, but Kenya is also slowly moving towards that direction. But we don't, maybe by making use of the recommendations that we have given out of what we have, it may speed up the process, because I know the new constitution, the new policy that was passed in Kenya, the 2015 Kenya national policy, has some clause of ensuring there is moving towards universal health coverage. But moving towards the universal health coverage, how, I guess, we need to have a clear structure in place, because again, the pooling has to be very effective, because whenever you move towards ensuring universal health coverage, that means you are ensuring there is everybody is accessing the quality services they need at wherever time they need them, and also the public are protected against the financial hardship. So again, there should be enough resources pooled. And of course, currently, I'm not sure the interplay that is there between the private healthcare sector that is already established, that is at 62%, compared to the public healthcare sector that is not really, the funding in terms of ensuring public healthcare services are run is still low at 9% instead of being at 15%. So again, I guess for the system to work to ensure there's universal health coverage, I guess pooling plays a key role, and also the funding at the public healthcare facilities should also be increased. Also, one thing I remember, there is the implementation of the free maternity program. Again, kind of slowed down the move towards the universal health coverage, and I guess that is because again the free maternity program was implemented by the third president, by the fourth president Uhuru, the last president. So he is not talking a lot along the lines of universal health coverage, a lot. So again, it depends on how the system, I guess, making use of the recommendations that we are giving and how the system is structured to ensure that universal health coverage is in place.
So we have a question online. We'll get to the ones in the room in a second. So online, we have the question, have there been any instances in which Kenyan policy development went against policy legacies? If so, what forces defeated the influence of the policy legacy?
Thank you. I could answer that question from this perspective. I guess the first answer is yes. At that point in time, I guess maybe I could say initially there was, maybe the best way of answering this question could be depending on the forces of influence, because before Kenya was under the one-party system whereby the presidents had all the powers to overrule and to do whatever they want to do. But because of the new constitution that has been established, that was established in 2010, I guess the system is more will more respect the policy legacies, because it has now stronger institutions compared to the former informal, weaker institutions. And because, and again, when the multi-party system came into play, right now there's a lot of accountability. When you go back to the initial structure I showed you in Kenya currently, it's really watertight. It's very strong. And in terms of understanding how policies now, the subsequent policies will follow after this, I guess it's even more challenging how maybe the previous part, how the new policies, legacies, or the new, if new policies have to come to play, I guess the past policies will have to play a bigger role in terms of determining of the future direction the country will take.
So the question has to do with changes in the Kenyan constitution that shifted some of these roles and responsibilities away from the president. So the question then is, who is the person in government that we need to be paying attention to currently that will lead reform in the healthcare sector in the Kenyan government?
I guess it depends on which policy reform you want to focus on specifically, but I guess the public are getting more voice, and so if you have the public behind you determining because they elect the leaders, and they kind of, more power is being given to the public, so I guess it will not be one specific individual who will kind of be at the forefront of running the show and determining where the direction of the country or the state will move. But I guess the public will play a very important role, because there are a lot of organized public groups that are coming into play. And
So the question in the room has to do with the essential healthcare package in Kenya and basically its impact on past failures in reform and potentially how it may impact future reforms.
Yeah, that's a good question. Thank you, Donya. So I guess to respond to your question, I'll respond it from two perspectives. One, Kenya, especially when it comes to procurement of key services like pharmaceuticals, and they have a central agency, the Kenya Medical Supplies Agency, KEMSA, and that does all the purchases of the key essential package. All those key drug lists that are there and the key services that are there are also determined by the national government, because the role of the national government basically does two things. It's basically regulation and policy making. But whenever it comes again to, because remember the delivery of healthcare services was fully devolved at the county government. So again, the county governments have the mandate to either pull the services from the Kenya medical, the goods and healthcare products and technologies from the Kenya Medical Supplies Agency or not. Because again, other than the KEMSA, we have another agency that distributes all these technologies known as MEDS, which is medical, medicines, essential and drug and services. It's kind of a standalone. It's a private entity managed by the Catholic Church. And it also has a lot of services. Unfortunately, MEDS is more efficient compared to KEMSA. So though there have been restructuring happening in the last few years by the USAID coming into play and supporting KEMSA to establish the efficiency of how it is, because in terms of how it needs to procure its services. And so again, it depends whether the county governments will draw the services from because they have the liberty to decide to purchase, because once the money has been transferred to the county government, they have the liberty to either procure directly from KEMSA or MEDS of their products. And again, now that running of the essential packages list, I guess, is in play, because they have to pay for it. So again, it depends on whether the committees will approve that list or they will change the list that is already in place.
So the question in the room has to do with the new county system that you had mentioned during your presentation, whether or not they are responsible for actually delivering health care and whether that may impact future reforms.
Yeah, thank you for that question. To respond to it, already kind of whenever you see the structure the way I detailed the mandate of the national government and the county governments, they are very distinct. The national government does more policy and regulation and also supporting the county governments to implement healthcare. And healthcare is among those services that were fully devolved, in the sense that the delivery of services is happening at the level of the county, the counties. So all the national hospitals, all the provincial hospitals that were there and healthcare facilities that were in Kenya previously were shifted to the region where those counties have their boundaries. And so the counties are taking care of the administration of those facilities, except in Kenya there are only 3 key healthcare facilities, and 2 of them are national teaching hospitals, and there's 1 psychiatric hospital that the national government takes care of. But all the other facilities in terms of delivery, and including even the healthcare providers, if you are in the region where initially you were working, and that region kind of, the border of the county government found you there, you automatically are seconded to be an employee of that particular county government.
So we have a question from somebody online. It's about the healthcare worker strike that you had mentioned during your presentation. Is that strike over? that my understanding? Okay, so the question has to do with that strike specifically, and curious as to what the demands were of the healthcare professionals and how the issue ended up being resolved by the government.
The issue was a bit broad in terms of the demands that were there. Yes, there was the issue of pay that was always coming top and flagged by everybody in terms of they needed more pay. But at the core of the strike was specifically the key essential services and technologies that are required at the facilities, because doctors who were seeing patients, but they didn't have the capacity in terms of health products. The facilities didn't have drugs. They didn't have the right equipment to be able to offer the services. And so partly it was resolved. They went back to work, and the government still is meant to meet their demands, because they already the government agrees to answer to part of the demands, not all the demands.
All right. Well, again, thank you very much, everybody, for joining us. Those who joined us here at the Health Forum at McMaster, and those of you who joined us online for the webinar. Thank you very much, Benard, for a very interesting topic on the Kenyan healthcare reforms. We look forward to your PhD work, which I'm sure will delve into this in a little bit more detail. So something to look forward to in the future. For those of you who are watching this later on YouTube, I'm going to direct your attention to the slide for a moment that's on the screen. So the first link is to information about the scholarship program here at the McMaster Health Forum and the Queen Elizabeth Scholarship. The second link is to our Insights page, which lists all of the webinars that are upcoming, and currently this is the last one of this batch, but there will be another list coming up in the fall. And then the final link there is to the blog page. All of our Queen Elizabeth scholars write blogs about their experiences, so you can go to that page and read those blogs. And thank you, everybody, for joining us, and we will see you in fall of 2017 for the next round of webinars. Thank you.